Okay, thanks for being here. Welcome to the Older Vermonters Caucus. We're going to have a continuation of our discussion on housing and looking at supportive housing, res care, nursing homes, and we have a couple of people here to talk, but always welcome input as we go along here. But I'll start with Helen, who's very supportive here in the legislature to me for understanding budgets and how all these pieces all fit together. And I thought it would be really good to kind of have almost like a one-on-one level on, introductory level course on how these supportive housing services work for older Vermonters and individuals with disabilities in our state, and on Disability Awareness Day here. So thank you for being here, Helen, and I appreciate your support to the Older Vermonters Caucus and coming here and talking to us. So I'll turn it over to you.
Wonderful. Thank you for letting me speak to you. So I'm going to share a PowerPoint. I'm going to look to Erica to tell me if anyone indicates that they can either not hear me or not see my PowerPoint. Let's see. So this should be happening.
It is.
Fantastic. Thank you.
All right. Thank you. All right. So I'm like this. Yes. All right. So I am, as Representative Noyes mentioned, Helen Laban. I'm the Executive Director of the Vermont Healthcare Association. And this is a trade association that's representing three types of residential long-term care. We've got nursing facilities or skilled nursing facilities, residential care homes, and assisted living residences. And these are all different types of providers that have residential long-term care, some of which have short-term rehab. And they all have different considerations for who they serve, what services they offer, how they are regulated, and how they are paid. So as mentioned in the introduction, I was asked to give sort of a one-on-one from a policy perspective of how that works. And I usually get like one-on-one on one aspect of it. So we're going to see how my 101 on everything is working here. So first, just some basic numbers, and to note that I don't represent all types of residential long-term care. So there are a few different types that are up there that we don't represent. So I won't try to represent them. But among our membership type, for nursing facilities or skilled nursing facilities, we've got 35, currently 36, but once in the process of winding down operations, about 2,800 beds. And then just notably, and I'll mention this a bit in the next slide, we have 2 counties with no nursing homes and 3 with only 1 available. And we're all going to add up to a point at the end of this presentation where we look at what actual capacity we might need to build in Vermont. And then for residential care homes, there are 84, by far the largest by type of facility, with 2,100 beds. And assisted living residences, there are 19 with about 1,200 beds. 1,250 beds. And to note on assisted living residences, another measure for that would be units, because this type of license sort of uniquely among these 3 includes a studio apartment type arrangement as the minimum size. So you would often have units for more than 1 person for assisted living. Assisted living residences, between them and residential care homes, they are also the type of assisted living residential care where you guarantee the ability to age in place. And residential care homes can often care for someone through various levels of needs, but they do need to apply for a waiver from the state to keep individuals who are determined to be what the state calls nursing home level of care. And there are many a diagram that define nursing home level of care, but that's just a couple of the distinctions between those 2. And then in this 3, nursing facilities and skilled nursing facilities are the highest acuity. Generally speaking, those would be distinguished by measurements to determine that when you are in a nursing home, that is the only appropriate placement for you. So it's the furthest along the continuum there. The other options do not have the level of skilled care that you need. And then it's also the type in here that has a designated short-term rehab element in addition to the long-term care. one thing that is, not in that housing, which is the context that we were discussing here, but in the world of healthcare services, location really matters for these types of facilities. Because yes, they are offering health services, they're offering assistance with activities of daily living, but they are also homes, and they are homes in communities. They are where people are living. And so this gets into wanting to be sure that there are options near where someone is coming from or where their friends and family may be. And then also, especially when we talk about assisted living and residential care homes, we often say that this is a particular service for which you should plan ahead so that you do have an opportunity to look at different options and determine where is the place that you want to make your home. So that is definitely a unique element of residential long-term care in the healthcare space. Also, that last slide is arguably the most interesting slide that I have. I know that I was told to make interesting slides, but it's really hard to get through the policy 101 without just doing some bullet points. I apologize.
No, it's all good.
Doing my best.
All good.
So, just a 101 on like how you can think about how regulations are different between these different types of providers. So skilled nursing facility regulations are set primarily by the federal government, with states performing inspections under federal contract. And if you are a real regulatory enthusiast, let me tell you, nursing homes are the place for you. Online, you can get the 1,000-page state inspection manual with a zip drive of another 1,000 pages of policy and procedure documents to explain how these facilities are regulated and how each potential citation is assessed. On top of all of that, work at the federal level, states can add rules of their own. So they can't do less than what the federal government requires, but they can do more. And a place where you often hear this come up recently in the news cycle for those who are following long-term care news cycles, is in the question of staffing ratios. So every nursing home is required to do an assessment of every resident and a facility-wide assessment that determines what staffing is needed to maintain the care plans for both the individual and for their overall population. So that's the federal requirement. On top of that, states can set a hard limit on how low you can go on your staffing ratios. So a common one is 3 hours of nursing care per resident day. Gets more complicated than that because everything gets more complicated than that, but that's the basics of it. It will not surprise you to learn that Vermont has staffing ratios in place. Other states that do not love regulations do not have staffing ratios in place, but Vermont is one that does, and that's often a key distinction between different states. When you look at residential care and assisted living, those regulations are set by the state government. These rules were updated in Vermont on April 1st of 2025, and that was for the first time in almost 25 years. I was still in college, barely. I was prepared to graduate from college the last time those rules were updated. And then, within that, there's a lot of state-to-state variability in the residential care and assisted living space. For example, many states do not have residential care and assisted living, they just have assisted living. And that's true for both the regulations and also what services Medicaid will cover, because there's not a required set of services the way facilities. So those are some of the really basic regulatory differences when you think about policy for these providers. Yet another confusing thing. So for these providers, we're mostly talking about a 65 and older demographic, but their primary public payer is Medicaid and not Medicare. So it's Medicaid that covers these long-term care services. In skilled nursing facilities, you have a mix of Medicaid and Medicare, and they're paying for two different things. Medicare is paying for those short-term rehabilitation stays. I fell down, I break my hip, I need care before I can go back home. That's a Medicare covered, so I'm over 65, that's a Medicare covered short-term stay for under 100 days. Medicaid is what pays for long-term stays. And down this graph that you have here, this is for nursing home beds. The state tracks payer utilization every month. So this is a pretty current representation of how that pie is divided up. Mostly Medicaid. Medicaid tends to fluctuate between like 64 to 68% of the whole, and that's in line with the rest of the country. Then just the other thing to note is that purple wedge is VA and hospice, which is another funding source. So we did some basics of regulatory, we did some really basics of payment. Each of those two slides has an hour-long presentation I can give on them. And here's a third one. This one probably has like a 5-hour presentation that could be done on it, which is workforce. A couple of things to know about workforce in this area, beyond the fact that we don't have enough of it, which is the overall theme. Almost none of our providers directly employ physicians. So primary care and specialty services are provided by external medical groups. Residents in assisted living and residential care homes, they have assistance with activities of daily living, which is not clinical. They also, depending on what licensure the facility has, but by and large, there's also access to some clinical services, RN services. Medication management is a very common one of those. But in general, anyone who moves in, well, not just in general, this is in the rules. It is true that anyone who's moving into a residential care home or assisted living residence needs to have their care services secured within the region before admission. Not necessarily so difficult if you're moving to a place in your own town where you were already at a primary care provider and a dentist and whatever else was needed. When we get to people who are moving into a provider that is distant from their home community, then you get to the place where lack of access to primary care services, for example, dental services, especially dental services, becomes a bigger problem, because that does need to be in place before you can admit someone. Nursing homes are they by definition, as we discussed in the last one around the regulations for staffing ratios, they are going to be providing nursing care. And they additionally are required to have a medical director and who has to be a physician, and a rounding physician, sometimes called a regulatory rounding physician, for primary care. And that's more or less accomplished through contracts with an external group. Hospital-owned nursing homes use physicians within the hospital. But in general, we're looking for a separate practice who we then contract with to provide this specialized set of services, which is nursing home and long-term care. Vermont, I shouldn't have said we there, I should have said Vermont, has the deepest residential long-term care workforce shortages in the country. And that is, in the particular areas where that is true, would be for LNAs and LPNs within the nursing options, and then also for medical directors and physicians who specialize in long-term care. And like I said, I have an entire presentation on that if you want to see the graphs that show it, but also it is not in dispute. We just do. We have the greatest workforce shortages.
Yeah, we heard in committee that this is one of the major contributing factors to emergency financial relief requirements. And, I believe the number is around 30% of nursing homes rely on, or 30% of the workforce is travelers, where the national average is closer to 5%.
That is correct.
So, this is something that we need to work on collectively here in the legislature, is how do we build this workforce? Because we're spending a lot of money on.
We're spending a lot of money. We're spending a lot of money, and also you want to have a stable staff for reasons beyond the cost.
Yes, absolutely.
Yeah.
And the care,
Yeah.
no doubt.
Apologies for being late, Representative Bishop of Colchester. A couple questions on this slide, if I may. I'm a little surprised to see the reference to, at least for assisted living, not that I have any expertise in this for sure, but the assisted living requires that you have those care services secured within the region. Is that by regulatory occupancy
Yes.
requirement? Okay, not facility by facility, it's not their feeling of best practice or liability or anything like that.
Correct. These are the regulations. Yeah, so just in a broad way, for any of these types of providers, they'll be required to do an assessment to understand someone's medical history before they are granted a place, because you'll want to be able to take care of them and meet their needs. And that's really what that stems from is just to ensure that someone will receive the services that they need. Some of which will be provided by the provider and some of which will be provided by providers in the community.
And I think it's implied, and maybe you said it, but would these facilities, if they could identify the person, bring these medical director or rounding physician resources in-house?
No.
No.
So for
they are
nursing
not.
homes, no, they're not gonna, there's a couple of reasons why they can't directly employ the medical director and rounding physician, because they aren't set up to be a physician employer. I'm trying to decide how detailed to go, but so the way the medical director works is that you're gonna need to have a practice that can do billing, that can do credentialing, that can do liability, that can do data analysis, that can do physician-directed services, and that's not a nursing home, that's a medical group.
And would it be a full-time or fractional medical director, if you will, is one medical director providing those services to multiple facilities?
So yes, actually, and if you really want the details, we have a 40-page report on how medical director contracting is structured in Vermont. So it depends on the size of the facility and what you are contracting for. So you could be a facility that has the same individual as both the medical director and the rounding physician, and you have a fair number of beds and a high number of those are complex needs residents, then you're probably going to employ one physician to do all of those roles, right? Commonly, if it's a smaller facility or a cluster of different facilities that have the same owner in one region, they will share a medical director. Some places it's not even that. So Rutland, for example, there's 3 different nursing homes, each have a different owner, but they collectively work with the local FQHC to provide the whole medical team. So it really depends on just the geography of where someone's attending, how the job is being split up, and whether you're going to be sharing that contract. And the size, and whether you're going to be sharing that contract. And we do have, again, if you want the details of how it currently looks in Vermont, we do have a pretty detailed report, but the answer is, if you've seen one contract, you've seen one contract.
Yeah. No, I appreciate that
Yeah.
overview, and you've saved me reading of a 40-page report.
It's pretty dense. It is not the most interesting writing that's ever been produced. I'm gonna own that. I did not write it. I don't know. I know that there were also folks on the call who are both assisted living and residential care providers are on the call, and I know that they've spoken often about the work they go to in that context to access the appropriate medical providers. So we can certainly, I'm sure when we open to discussion, have more conversations about that because it is a challenge. Just the last kind of big challenge I wanted to get to is the underlying capacity. So this is, when just the number of beds or units available and how that matches with demographic trends. So here we have just list some basic dimensions that you look at for capacity. I am going to boil it down to something simpler, but you can look at the number of beds total. As we talked about at the beginning, you can look at those locations relative to different communities, relative to available care teams. Number of beds we've already mentioned with the staffing. So in this case, I'm talking about basic staffing, like maintaining the ratios for staffing, which for some providers has historically been a struggle. And we're world where when I say historically, I mean during COVID and since then. So that's my context for historically. There's access to workforce for more complex needs. That's especially true in nursing homes, you know, to the question of having an assessment before you admit someone. If someone has needs, someone can have needs that are beyond that and regularly do have needs beyond that minimum staffing requirement. So the minimum is more theoretical one than an actual one because you have to actually match what an individual will require. And then we just talked about qualified providers for assisted living and residential care. And then also there's specialized considerations. So for example, Mission Care, which is a facility that the state contracted with an operator for, I think it's 2 years ago now, to provide specialized care for individuals who are having trouble finding a placement after hospital. So you can also have dedicated options. Other states have nursing homes that are dedicated to traumatic brain injury, or some that are dedicated to specialized memory care. So that's also something we see for capacity building. The data around this is best on nursing homes, so apologies to assisted living and residential care homes, who we definitely also want capacity in. But because whether or not someone requires a nursing home is very structured, and it's structured at a federal level, and there's so much reporting every month, the data for nursing homes is both better in general, and also if you want to compare with other states, that's one where it's going to be an apples. Well, nothing's an apples to apples comparison, but it's going to be closer to an apples to apples comparison. So hence me talking about nursing homes for the next couple of slides, not because we don't care about capacity across the board. So this is showing Vermont's most recent census compared to national trends. So this is the percent of licensed beds that are filled. We are more full than other states. Another interesting thing in this graph, so this is obviously showing the dip that happened during COVID-19. That's pretty obvious on this graph. The amount that the nation is above the lowest point of COVID-19 is about the same as Vermont is above the nation. So we dipped down similarly to the rest of the nation during COVID-19, and then we went back up by a lot after that, which there's a lot of reasons that that's not entirely surprising, some of which are underlying demographics, which we'll get to shortly, some of which is also delayed care and increased acuity during those COVID-19 times. And some of it, I mean, I won't call it other states, but Vermont did make extraordinary financial relief available, unlike other states. So we invested from the jump on bringing us back to capacity, and we're seeing that pay off now with our current census.
I'm sorry, just for clarity. The graph is showing the national trend, and that's what representing Vermont.
And the dot is Vermont today.
Or 80%.
Yeah. So we looked similar to the nation going along, and then we invested a lot and had a pent-up need and jumped up to 88%.
So someone might wonder why you see a capacity that is at 80% and not 100. Like,
Well,
what? Now, maybe this is going to be coming up, but
it was a great introduction to my next slide. Yes, Representative Joyce, I can tell you exactly why. And I know Dale has a similar slide to this that they presented before, but right, full census is not 100% of licensed beds. If it were 100%, I would be very concerned and perhaps searching for a job elsewhere. So one reason is that some beds are for short-term rehab, and that is both has high turnover and also a seasonal element, right? Slipping on ice in Vermont would be a seasonal uptick in that. Some rooms are licensed for multiple beds, but they aren't used that way. For example, infection prevention protocols, for the obvious reasons. Resident conditions that require no roommate. We see this in advanced dementia as an example. bed holds for hospital stays. You also tend to, if someone's on hospice and you're giving the family space at end of life, you don't add a new roommate. And also legacy licenses for old configurations of beds. So there was a time when Vermont allowed triples and quads. That time is no more, but some providers will held on to those old licenses in the anticipation that if they renovate their building, they'll build out some more space. So that's some of those reasons. And then additionally, nursing homes will slow down or pause admissions for a variety of reasons. Renovations would be an obvious one, like the Vermont Children's Home recently was showing low census because they were renovating a unit. Key staff transition, if you're bringing in a new administrator, you're training up a new clinical staff, you're not going to overload yourself with new admissions. If they're going through licensing, and then of course, if you have a flu or COVID outbreak that you're trying to contain, the recommendation from the Department of Health may be to pause admissions. But the general consensus between that slide and this is that we've had significant workforce shortages. We may have a little bit of margin to rebuild, especially around like complex care, but we've got a quite robust census right now.
A question about the second bullet point, licensed for a certain number of beds, but for operational reasons, whatever it may be, I may be licensed, running facility license at 60 from X number of years ago, but now I run at 52, and I don't intend to ever fill 60 beds. Where's the adjustment in that? Because it may give a false sense of vacancy.
Yeah.
When I never intend to return to 60. So is it only at the next licensure turnover, or when do I state an intention to run now at 52 and license at 52?
So I mean, you can de-license, and you see, like, if you watch if you look at the entire spreadsheet that the state has, you can track since 1998, like who's changed their license levels. So it less turns into like a specific, I mean, we could interview people and figure out the specific number that are licensed, but probably not going to come back online until there's an upgrade to the building. But more realistically, we just keep it as a rule of thumb that all these things added together, you would rarely see an overall census statewide average above 90%. We say at a facility if it gets above 95%, and that's really truthful. So usually the way we handle it in policy discussions is just to say, all right, we add all these factors together and we expect that when a state is on average 90%, they're pretty robust.
Makes me think of the conversation around unemployment. We're not going to have zero unemployment.
Right.
Right.
We have a question online. Brett, you want to go ahead?
Yeah, thanks, Dan. And thanks for this presentation. I'm just curious about your statement that Vermont census is robust. And I'm kind of curious about the census versus demand. You noted that there are, for example, 2 counties for which there are no facilities. Presumably there are people there who would go to some place if they could, but they can't. So
yep.
What can you say about demand versus the census?
I can see that's my next slide. So there's that. I would also say that, right, we know that there is demand beyond what we're currently capable of providing, and that we can get, usually for a skilled nursing facility, the admission is going to be from a hospital stay, or often it's going to be from a hospital stay. It can be directly from the community as well. So one way that we know that there's a demand that exceeds what we can currently serve is just that the hospitals tell us we have X number of folks who we'd like to place in a nursing home, or home health tells us, and that's usually the way we keep tabs on it. So we know that we currently don't have the capacity to serve everyone we need to. Usually those are people who have additional complexities. So there may be a bed in their region, but there's not a bed plus whatever the specialized care is they need. I use ventilators as an example, even though that's like a super specific thing. But right, if you need a ventilator unit, and there's only 11 in the state, then you're not gonna flex to add one, in a place that doesn't have one yet. But like that, all of that pales in comparison to the next driving force. And I'm gonna get a little bit more general before I get, then again, more specific to Brett's question. So, and this is me super summarizing a bunch of literature. So if anyone is really dorky about this and wants like the academic references, go for it. But in general, age is the primary determinant of demand for nursing home services. And HHS even stratifies it by 5-year increments, how that age category affects demand. And what this slide is showing, this is from a presentation from the Department of Labor. So that dark green is 2022, the light blue is 2010. And I want to bring attention to kind of two sections here. One is, and this is not going to be surprising to you, and we're going to be going into a bit more in the next slide, and that ages 65 and up, we're seeing a clear dramatic growth in demographics. So those are the ages where we have statistics on, generally speaking, how many folks are going to need a nursing home bed, either for short-term or long-term. Another thing to note here is that in that age 40 to 54 category, my own category, where you see a big drop since 2010. I don't love, this is more in the assisted living and residential care home world. Often in policy in that lower acuity setting, we talk about family caregivers as an alternative to residential care, which is wonderful. 100% should have lots of support for that option. Plenty of people love that option, and in fact, it is a source of workforce for long-term care. Someone is a family caregiver, and then they decide, you know what, this kind of works for me. I'm going to go back to school and become an LNA. Like, that's a wonderful option. That being said, to rely on that for capacity in a policy sense is problematic for a lot of reasons. One, so I am a woman, and I'm not confused about what demographic statistically is dropping out of their careers to provide these services. So don't feel great about driving women out of the workforce who don't want to leave. Additionally, I have no children and a significantly older husband. So I know for sure that's not going to work for me as something to rely on. So don't like it that much as something to rely on for policymaking. And often when you look at states, like ways to compare states in terms of how prepared they are, again, especially in that assisted living and residential care world, for future capacity needs. Nationally, you'll see that ratio of 40 to 55-year-olds compared to the 65, 75, things you do 75-plus-year-olds as an indicator of whether you are low capacity. Vermont shows up as extremely low capacity in those ratios. So on nursing homes, I said that there's a fair amount of statistics around age, if you look at it as a primary determinant of demand. We can do math here on this, and we don't need to look that far in the future. So Department of Labor is predicting a 40,000 person increase in Vermont by 2030. We can, like we were talking about a few minutes ago, we can look at our current capacity and say, all right, we have maybe, if we do a lot, we can push that margin up a little bit, but not that much more. Then we can take those ratios and say, well, just based on demographics, by the year 2030, we would need 1,600 more beds. And that would mean expanding our current capacity by more than 50% in the next 4 years.
Just repeat that one more time, please.
So statistically, we would need to expand our current capacity by more than 50% in the next 4 years. And we know that we're not going to do that by building new facilities, because if we were doing that, they would be in the process of getting built right now. I'll just slide left blank, awaiting solution, representatives.
That's why I wanted you to repeat the question.
I've got to duck out and get lunch.
So the way I personally think about this, and this is Helen's own personal way of thinking about this, I invite plenty of conversation on other ways to think about this. So these illustrations are from climate change policy. It's the Pacala wedges, if you want a specific name for it. But this is often used to illustrate kind of the framework that I use to think about it, which is that, all right, this is close enough and we know enough to know that to match the sort of locked-in demands of these underlying trends, there is no single solution to that, right? If there were a single solution, we would know it by now and we would be doing it. And we're generally biased to look for a single solution. Additionally, we're biased to look for that solution within our own domains. So it feels super hopeless when you put it in that context. If you add a lot of changes together on the margins across many different disciplines, though, you can reach the desired impact. And so we sort of know from just hard numbers that that's what we're going to have to do in Vermont, is add a lot of margins or marginal changes to get up to the big impact, which is difficult to pull off. Since this is a climate change slide from the year 2000, you know that it hasn't worked there yet, but it is sort of the framework to work for. So, here's just an example in no particular order of different marginal changes that can bump up that capacity in a short time frame. And added together, we could make up this difference.
Oh, for God's sakes.
Yeah, so it's not impossible, nor is it easy. With apologies to both Matt Garowitz, who I stole this from in a Department of Labor Economy presentation, and Hadestown. It's both pessimistic and optimistic, right? Like, yep, we've tried this before, we've failed at this before, but we've gotten maybe a little closer to our goal. So we're going to keep trying it again and again and hope that it turns out different this time.
No,
And what else are you going to do?
I'll tell you.
Do you have a question, Luba?
No, I'm going to help you with an answer. Whenever you want it. I just want you to know, am I the only caregiver here? Am I the only consumer of these products here?
Who's joining us today? You may be. However, we
First
get a
of all-
lot of views on YouTube, so there
Well-
could be other caregivers watching.
We need the Olympics top views.
But you should have more of us here. I don't know if you're ready for me or not. I did a lot of testifying. My husband has Alzheimer's. For 6 years, 4 years, I went through hell. I'm going to say something in a state that I love. Vermont does not treat its elderly people well across the board. I mean, that's a fact. I was horrified of what I've gone through. Horrified. I have been horrified of how I've been treated. I don't usually am a person who lets that happen to me. I speak my truth. I cannot tell you the nightmares that I have gone through with trying to get my husband placed. It's been awful. People do not return your calls. People lie to you. People do not know what they're doing. The facilities are not good places, a lot of them. I do not have $150,000 to spend every year. I am horrified. You have to spend years on waiting lists. You get someone in before they get bad. Now, why would I want to do that to my husband? But that's the name of the game. You get sheets and sheets of facilities and you call them and you quickly find out they cannot cover the needs of someone with Alzheimer's. I have sat on waiting lists for 6 months. I have given my husband a tour. I have been told he's fourth in line. No one ever called me back. 4 months later, I found out he's gone to 14th in line. Why? How come? I don't understand it. Oh, I'm so sorry. I asked, why? Why are you not taking my husband? I found out from legal aid they don't have to give me an answer. I have found out from legal aid that they can move my placement anytime they want without telling me. Oh, you've just ruined my life. You have to, I believe, after being in this, after being on NPR, after being on Channel 3, after being involved with Alzheimer's, you have to change your paradigm. And that's what I did for my husband. I got so sick of dealing with these people. They were causing me more frustration than my husband. I have reinvented a system for my husband. You can do that too. And it's sitting right in front of your noses. But you keep taking from elderly people. Okay? I have an incredible system for myself. Is my husband going to die of Alzheimer's? Absolutely. Is he getting worse? Absolutely. Is he going to be in a nursing home? Absolutely. However, in the meantime, I am trying my hardest to keep him out of residential care. And I'm going to give you the secret. The secret is adult services in Burlington. And the state, in its wisdom, has cut them, which is unbelievable. This has saved me and it has saved my husband. And I can't say enough about this service. He goes 4 days a week. Yes. What?
I appreciate your what you've been, how you've been a caregiver for your husband, and your how you're all of your truths that you've been saying. And I think about, that's why I run this caucus every week, is to raise awareness of our services and supports for older Vermonters in this building. And it's not always easy, as you can see.
I'm not saying you're not doing that.
Here, and I want to have you come back, and maybe we should have a more of a robust conversation on caregivers and their experiences and how we can.
I can't tell you how many times everybody has done that.
Yeah.
I've listened to the same
Hear your
thing. Frustration. It's not for myself. I'm happy. I can go away in my cave and be quiet. I think about all the other people who are not happy and have not advocated. I don't want to hear another. I know what caregivers go through. I want to see something done. The state has cut adult services. You had 3 in Chittenden County. It got cut because of COVID. COVID's over. This is a way you can save money. You can give the community resources together, and you can keep people out of residential assisted living.
Thank you.
You're welcome.
I appreciate your input, and I know how hard it is in this building to advocate for these services, because I'm trying every day. I don't know what else to say, but we will continue to talk. Thank you. So, yeah, are there any other questions or comments on, I know we have Kaylee here, our long-term care ombudsman, so thank you for being here today. We only have a few more minutes, so, and there's gonna be another, this room is gonna be flooded with people.
We can hear them
I don't have
going
to leave though,
outside.
because my committee is gonna continue right here in this room.
Yes, the folks on Zoom may not hear the
Yeah,
low roar from just outside the door as they wait, but you know what, we've done this, we've got important things we're discussing.
yeah. So I really appreciate, Helen, your presentation today and your input and helping me understand kind of the complexities of in this building around the funding and how we have a lot of work to do, as evident by Luba's testimony to us today. So, but thank you for being here. And I wanted to just quickly thank Ren, who is my intern I'm working with from UVM. She's so helpful in helping me organize this caucus and everything else that I'm trying to straighten together. So thank you, everybody. And we'll see you next week. I'm trying to put together a talk on the our healthcare grant that we got from the Fed. So hopefully I'll have some sort of a presentation on that next week. So